Good afternoon to everyone, and first of all, thank you for giving this opportunity. We'll start directly with our today's topic because of limitation of time. So, most of the part of our treatment and side effects previously covered by the Archana madam. So, I'll just give a brief introduction of what is the need of this target therapy. So, when we come to the diagnosis of lung cancer, initially treatment was based on only histologic basis, which was mainly a conventional chemotherapy. But now, as our knowledge is evolving in cancer, we are now know there are many targets which are driving this cancer, from proliferation to invasion to metastasis. So nowadays, whenever we are able to diagnose the lung cancer, we go on to the deeper the molecular profile of the cancer, which is the driver mutation and what is the PD-L1 marker. So basically, I will cover the target part, and the PD-L1 marker immunotherapy will be covered by my next colleague, Dr. Sunil. So now in decision making for treatment part of lung cancer, we in addition to histologic subtype, we also do the genotyping, and based on the whatever molecular marker we are getting, in addition to histology, we decide the treatment. So this is the evolution of the lung cancer treatment. When it was initially just classified in non-small cell and small cell lung cancer, but now after this molecular profile, this non-small cell cancer we are dividing into adenocarcinoma and squamous cell, and a few other variants which are very rare. And among these adeno and squamous, we again divide them into these different kinds of types based on whether it's a EGFR positive or HER2 positive, BRAF, PIK3CA, NRAS, NTRK mutation, RET mutation. So these are few common mutations which we are knowing, but in addition to that, there are many other mutations which are still at current era we are not knowing. So these mutations are nothing, but they are maybe locating at the cell membrane or nuclear membrane, and they are having a different component. Few parts are extra locating above the membrane, few throughout the membrane. Few parts are just translocating the signal from the cell membrane to nuclear membrane for different processes. And how we detect these mutations? So there are different methods based on basically from immunohistochemistry, where initially we process the cells tumor block for the immunohistochemistry for common marker which we are knowing, and if those are not detected, then we go for the deeper methods, either by RT-PCR, FISH, or now the newer method is the next generation sequencing. These are nothing but having few advantages and few disadvantages. If you go by ISC, it is a simple method, and we can get the results in 48 hours. Similarly, with FISH also we can get a result in 24 to 48 hours. But and other methods like NGS and RT-PCR, this will take a week to get reported. And advantage of RT-PCR and NGS is that they are having a deeper coverage, so that more markers can be detected by NGS method. And ISC and FISH, they can detect the whatever we just wanted, whether EGFR or ALK or ROS, but they can't detect any other mutation. They can detect just what we want. But in NGS and RT-PCR, we can detect the many other mutations which may be of significance and not maybe of not no any significance. And there are many others like Sanger sequencing and few others, but right now we are just concentrating on either RT-PCR, FISH or NGS. Similarly, if you come to the treatment profile of the lung cancer, initially just based on the histology, whether it's a small cell or lung or small cell, we were giving conventional chemotherapy. And now in the last decade, we are now aware of the multiple targets. So our treatment has changed from conventional chemotherapy to either a target therapy or immunotherapy. So when we come to why we shifted from chemotherapy to immunotherapy, this target therapy. So if you see the mutation, almost you can see that in the left side is the Western data, and the right side is the Indian population data from Tata Hospital. You can see that almost 17% in the Western population are EGFR positive, and few are KRAS positive, and remaining 5 to 10% are either ALK or BRAF or PIK3CA mutation. But when we come to Indian population, approximately 30% patient, 29% patient were EGFR positive. Means out of 3 patients, every 1 patient is having EGFR positive. And when we see other mutations, so approximately 45 to 50% patient were having some mutations. And for these mutations, right now we are having a good target drugs which are giving more benefit than the chemotherapy drugs. So when we see the chemotherapy benefit, multiple treatment regimens were tried from cisplatin paclitaxel, cisplatin gemcitabine, cisplatin docetaxel, carboplatin paclitaxel. Overall, the median survival remained 8 months in different meta-analysis, and 1 year survival was shown to be 30 to 40%. These were patients who were enrolled in trial, but when we come in real world data, patients were not in a good shape, so maybe survival was around 10 to 15% only at 1 year. So out of 100 patients, only 10% or 15% patients were able to survive till 1 year. But now, based on the different drugs available for these target mutations, like EGFR, ALK are more common in everywhere. So for EGFR, there were different generations of drugs were developed. From first generation to right now, we are having a third generation of drugs. So earlier it was gefitinib, erlotinib, efatinib. Then came the dacomatinib, and right now we are having osimertinib, third generation drug. Similarly, for ALK also we have a crizotinib and ceritinib as the first generation, followed by lorlatinib, alectinib as the second generation, then brigatinib as the third generation. The advantage of this newer generation drugs is that over a period of time when we give first or second generation drug, these receptor or these targets, they develop an additional mutation and they become resistant to these drugs. But these newer generation were able to even act against those newer mutations also. So they are having a more prolonged duration of action. But over a longer period of time also we can see a resistance to newer generation drugs also. So similarly, in addition to EGFR and ALK, we are having a drugs almost maybe 8 to 10 mutations. Like for MET and ROS, there is again crizotinib or ceritinib. Then HER2, we have a trastuzumab and afatinib. Similarly, for this MEK inhibitors, we are having a trametinib and NTRK, we are having a lirotinib, entrectinib, and RET mutation, we are having this capmatinib and lelmatinib. So when we compare the results of this targeted therapy with the conventional chemotherapy, we can clearly see that with EGFR targeted drugs, the overall survival of approximately increased from 8 months, which what we have seen in the chemotherapy era. It is now approximately 20 to 24 months, means from less than a year now we are able to see a survival till 2 years, and this data was with first generation drug. When we come with the newer generation osimertinib, we can see a survival approximately 36 months. From a year now patients are able to survive on an average 3 years. But there are exceptions also. There are few patients who are surviving 8 years or 7 years also, and still they are having a follow up with us. Similarly, also with ALK also we can see approximately, this is from data from Tata, 5% of patients are having a ALK positive in out of 100 patients. So if we see that approximately 30 patients are EGFR positive, 5% patients are ALK positive, 35%, and remaining 10% are other mutations. So approximately out of 100, 45 or 50 patients are having some mutations, and if we treat those patients with only chemotherapy, the survival will be very poor. But if we go by sequential therapy, first target followed by chemotherapy, they are surviving in multiple of years. Similarly with ALK also, this is a data bombed by Dr. Vanita ma'am from our Tata only. You can see that median survival was increased as opposed to chemotherapy from 11 months to 40 years. So more than 3 years they are surviving in stage 4 cancer, which is, if you go a decade back, which is a rare phenomena. Similarly, if you see for other mutations also, though they are very less, maybe approximately 1 or 2% or less than 1%, but those, if you detect those mutations and we are able to give a drug to them to target those mutations, they are again having a same benefit. They are surviving in their disease remaining controlled for years, and they are surviving in multiple years. So if you see already, as informed by Archana madam, there was a stage 1 and stage 2 patients. The survival was, though we say a curative patients, they are surviving approximately 63% or 60% patients were curable. Approximately 40% patients were still having a relapse. And if we see the stage 4 patients, they are with this target therapy, whatever the newer drugs are available, they are surviving approximately. If you see a 2/3 patient, means 60% patient are surviving in 3 years or 5 years with different drugs, either a newer generation ALK inhibitor or newer generation EGFR drugs. So now, because of this, and if you go to stage 3 patient, where again we can treat with the radiation therapy or surgery if feasible. So survival for those patients also at 2 years, maybe hardly 20-25% patient were able to survive, and remaining patient either relapsing or dying. So even stage 3 patient, we are saying ki though it is a curative, we are seeing a benefit only on 20 or 25% patient. And in lung cancer, in this stage 4 patient, we are seeing approximately more than half or 2/3 patients are surviving in multiple of years. So now there is a debate. Maybe in current coming few decades, we will again go back to review our decision whether to definitely should treat with these localized patients or locally advanced patients with the surgery or radiation, or we should go ahead with the target therapy because of the excellent result given by this target therapy. Even in current era also, those patients who are frail, borderline, we think they are not fit for surgery, and if they fortunately comes positive for mutations, maybe we give preference to start with the target therapy, because we are knowing that with the target therapy they may survive for may survive with better quality of life than surgery or radiation. Similarly, maybe in coming decades, with more availability of target therapy, we will able to prefer, maybe we will able to prefer target therapy drugs as opposed to the curative treatment. Similarly, this toxicity part was already covered, but I'll just take a few minutes. So common toxicity is skin related. So it will be from few rashes like macules and papules. It will be hand-foot syndrome, where we need to stop the drugs and monitor the patient. And if stop the drugs and monitor, and over time we need to modify the doses if they are able to tolerate the drugs. Similarly, in GI, we can see from common nausea, vomiting to diarrhea, which may be life threatening if we can't give the proper attention to those toxicity. And it may cause a myelosuppression. Against there will be fall in WBC counts, platelets, hemoglobin, and in liver and kidney also there will be transaminitis, hyperuremia, rise in creatinine. So whenever we start the target therapy, we need to, at least for first 2 months, we need to monitor patient very strictly with the weekly monitoring of the hemoglobin, liver function, and kidney function. In addition that, they have a common effect on heart in form of QTC prolongation or rhythm disturbances. So at least for a month or 2 months, we need to follow those side effects very closely. And if they are able to tolerate those, for first and 2 months, then we can safely keep them follow up in 3 or 4 months. So whenever they are coming to OPD, we need to monitor their vitals very specifically, because in addition to those biochemistry and lab parameter derangement, they are prone to have a hypertension. There will be bradycardia. There will be this pneumonitis is very rare, but it is a life-threatening. We need to detect the pneumonitis very early. So clinically, we need to see the respiratory rate, SpO2, and other tests we already discussed, that RFT and this liver function and renal kidney function and electrolytes we need to monitor, because though side effects are very rare, but it can happen and it can be life threatening. So at least for the first 2 months we need to monitor them very strictly. So this is in short about TKI therapy. So in take home message is that because of the advantage it is shown as opposed to the conventional chemotherapy, where patients are now from less than a year surviving in multiple of years. So it is a now preferable therapy. So each patient who are coming to with lung cancer, we need to strictly do the molecular profiling, and based on the molecular profiling result, we need to decide about the treatment. And if we decided to start the treatment, we need to, at least for the first 2 months, we need to follow the patient strictly for side effects, because side effects are less with the TKI therapy, but those side effects are very life threatening. So we need to identify those side effects, and we need to accordingly to manage the dosing. Thank you for your kind attention.
Thank you, Dr. Ajay. So Dr. Ajay has again put light on the fact that we have been discussing that targeted therapy, if monitored well, the TKI toxicities, if we monitor well, it is giving a improved survival outcome. and the patients are being benefited by this.